Hello. Today's lecture will address the behavioral objectives for week 7 in the syllabus. Because the file is so large, this will be presented in 2 parts. Make sure to watch both parts for avoid missing critical information. So this is the content for the B portion for week 7. So this is the second half of the lecture for week 7's behavioral objectives. Let's begin. Iron deficiency anemia is the first condition we will talk about. Maternal iron stores are adequate for the first 4 months of life. By 6 months, neonatal iron stores are depleted. Infants need iron if they are breastfed because it doesn't contain a large enough quantity to meet the infant's iron needs. An formula-fed infant at this time should be given a formula that is fortified with iron. Also, they can start eating iron-fortified rice cereal between 4 and 6 months of age. People at risk for developing anemia often have a poor diet, infants that are born prematurely, people that have hemorrhaged, girls with heavy cycles, vegetarians, an infant that drinks cow's milk. Please know that it is necessary to also have adequate amounts of folic acid and vitamin B12 to form the hemoglobin, because a lack of this can also cause anemia. Signs and symptoms of iron deficiency anemia include muscle weakness, fatigue, shortness of breath, poor sucking, pale skin, pica. Pica is the eating of non-food items like clay and dirt. Headache, dizziness, lightheadedness, slowed thought processes, decreased attention span, apathy, depression, moist and cool skin, decreased blood pressure, an increase in the heart rate. They will have an activity intolerance due to weakness. Diagnosis, history and physical. They will have a low hemoglobin, low hematocrit, low serum iron concentration, and a high total iron binding capacity to compensate to absorb more iron. Please remember, it is very important to know your labs. You are required to know all of your CBC labs for this exam, as well as your metabolic panel. Treatment. No cow's milk until the child reaches 1 year of age. Iron fortified cereal if they are breastfed, or formula fed with making sure the formula does have iron until they are 18 months of age. Iron fortified foods, iron supplements, iron dextran may be given. If this is given, this is injected. I am in a Z-track method. Please do not massage. If a child is given IV iron, called InFed, here this requires a test dose because of the risk of anaphylaxis. Iron supplement side effects include constipation, dark green, tarry or black stools, GI distress, vomiting, or diarrhea, more often constipation than diarrhea. For severe anemia, they may even require a packed red blood cell transfusion. Patient education. Take iron with vitamin C or citrus on an empty stomach to aid in absorption. Do not take with milk or milk products. Encourage to feed the child developmentally appropriate iron foods such as iron fortified cereal, spinach, eggs, meat, dried fruits, kidney beans, peas, and remember, no more than 24 ounces of milk in a 24-hour period. This might be taking the place of the healthy iron-rich foods. Take iron with a straw or place the syringe in the back of the mouth and then rinse the mouth to avoid staining of the teeth. The child is receiving enough iron when the stool turns green. Sickle cell anemia. This is an autosomal recessive inherited condition when a patient has a partial or complete replacement of normal hemoglobin with abnormal sickle hemoglobin. Fetal hemoglobin is produced throughout gestation and at birth is contained in all of the infant's red blood cells. After birth, the infant begins to produce non-fetal hemoglobin. The normal lifespan of a red blood cell is about 120 days. After 4 months, nearly all of the red blood cells that were present at birth have been broken down and new cells have been replaced. And they've been replaced possibly with the hemoglobin S, so the child is vulnerable to sickle cell crisis. This is generally found in African Americans and sometimes Hispanics. The structure of the hemoglobin changes. Hemoglobin S has a decreased oxygen carrying capacity. When oxygen is released, the red blood cell shape changed from round to crescent shape. Sickled red blood cells only live about 6 to 20 days instead of the normal 120. This can result in hemolytic anemia. Signs and symptoms: sickling can be triggered by fever, dehydration, emotional and physical stress, and hypoxia. The signs and symptoms result from obstruction caused by sickled red blood cells and or an increase in the red blood cell destruction. An increase in red blood cell destruction, also called hemolysis. The signs and symptoms you'll see here are anemia, pallor, fatigue, hemodilution, and possibly heart failure later on. Signs and symptoms due to obstruction or the vaso-occlusive or thrombocytic crisis can include issues with a wide variety of the body parts. Know that a vaso-occlusive crisis is caused by sickled red blood cells that have clumped together and have blocked the small vessels. This can cause an increased blood viscosity, causing sludging, increased hypoxia, and then an increase in the sickling. As just stated, these signs and symptoms are based on the location of the vaso-occlusion. Know that local hypoxia, tissue ischemia, and tissue death can occur. So signs and symptoms for extremities during a vaso-occlusive crisis include pain, chronic ulcers, osteomyelitis, osteoporosis, kyphosis, lordosis, necrosis of the femoral head, neuropathy, and weakness. The eyes, signs and symptoms include retinopathy and blindness. The brain, CVAs, paralysis, seizures, and death. GI, the liver, there can be vessel blockage causing hepatomegaly and cirrhosis. Spleen, a splenic sequestration crisis can be an emergency. Here you would see a pulling of the blood in the spleen causing anemia, decreased blood volume, and shock. Here you would see signs and symptoms of a sudden onset of an enlarged spleen, tender abdomen, faintness, pallor, changes in the level of consciousness, rapid breathing, a drop in blood pressure with an increase in the heart rate, followed by a drop in the heart rate. The patient can literally die in minutes to hours. Kidney, signs and symptoms here, we could see hematuria, diuresis, enuresis, and progressive renal failure. The lungs, here we can see chest syndrome. This kind of looks like pneumonia. Here you would see chest pain, fever, cough, anemia can lead to COPD and cor pulmonale. Hand-foot syndrome, here you have pain and swelling of the hands and feet. This usually resolves in a few weeks. This is most common in children 6 months to 2 years of age. Diagnosis, there is a newborn screening, and please note that early diagnosis before 3 months enables us to help an early intervention to minimize complications. The sickle turbidity test, or the sickle dex, is used for screening purposes. Here a blood sample is taken and you can get results in as little as 3 minutes. The hemoglobin electrophoresis test is accurate and rapid, and it's a specific test for detecting the homozygous and heterozygous forms of the disease, as well as the percentages of the various types of hemoglobin. This lets you know, does the child have the disease or the trait? The aim of therapy is to prevent conditions that enhance sickling phenomenon. The goals of medical management are usually directed at supportive and symptomatic treatment, such as providing bed rest to minimize energy expenditure and oxygen use, hydration through oral and IV therapy. Please note it's not uncommon for patients to be on 1.5 to 2 times of the maintenance fluids. Electrolyte replacement, since hypoxia can result in metabolic acidosis. Analgesics for severe pain from the vaso-occlusion. These medications can include ibuprofen, dilaudid, methadone, and PCA use, which is usually using morphine. Blood replacement can be used to treat anemia and reduce the viscosity of sickled blood. Antibiotics are used to treat any existing infections. Hydroxyurea, which is an antineoplastic, can be used in severe cases. This helps to reduce the frequency of painful crisis, acute syndrome, chest syndrome, and it can even decrease the need for blood transfusions. You can have fewer blood transfusions. Side effects are usually mild, like headache, mild gastrointestinal symptoms, abdominal discomfort or nausea, dermatologic changes like skin hyperpigmentation or darkening of the nails. They can develop a myelosuppression, which is reversible. It's typically neutropenia. Pneumococcal and meningococcal vaccines are recommended for children because of their increased susceptibility to infection. Oral penicillin is typically recommended by 2 months of age until the child is age 5 to prevent pneumococcal sepsis. Short-term oxygen therapy is given to help the child with respiratory difficulties. Severe hypoxia must be prevented to prevent severe systemic sickling. A lack of oxygen can cause it to be fatal. The thing is we also want to avoid prolonged oxygen use because this can depress the bone marrow's functioning and further aggravate the anemia. Painful priapism, this may be treated with aspiration of the corpora cavernosum. Demerol is not recommended. It does cause CNS excitability and it can even cause seizures. We want to advise parents to be aware of situations that may cause dehydration, such as hot weather. They also need to be able to recognize signs of reduced intake, such as a decrease in urine output and increase in thirst. Also, avoid physical exertion, emotional stress, low oxygen areas such as airplanes and altitudes over 7,000 feet. We want to avoid overheating because this can increase fluid loss. Avoid cold compresses because it can increase vasoconstriction and sickling. Pain management with opiates is often necessary. And please note, don't worry about addiction. That is very rare. Genetic counseling and support groups for the family is also important. Signs and symptoms that you want to report. Chest syndrome. Here, this is that severe chest pain that sometimes spreads to the abdomen, a fever of 100.3 or greater. They're congested, they have a cough, they have dyspnea, tachypnea, retractions, and a declining oxygen saturation. We also want to report signs and symptoms of a CVA, also called a stroke. Here you could see jerking, twitching of the face, of the twitching of the legs or arms, seizures, strange abnormal behavior, and inability to move an arm and or a leg. They may be staggering or have an unsteady gait. They may have a stuttered or slurred speech. They may have weakness in the hands, feet, or legs. They may have a change in vision, also severe unrelieved headaches, and severe vomiting. Sadly, the major cause of death is infection. Beta thalassemia. The most severe form of beta thalassemia, thalassemia major, is also called Cooley's anemia. Beta thalassemia refers to an inherited hemolytic anemia characterized by a reduction or absence of the beta globulin chain in the hemoglobin synthesis. There are 3 types: thalassemia minor, thalassemia intermedia, and thalassemia major. Thalassemia major, or Cooley's anemia, results in a severe anemia that would lead to cardiac failure and death in early childhood without transfusion support. The postnatal hemoglobin is composed of 2 alpha and 2 beta polypeptide chains. In beta thalassemia, there's a partial or complete deficiency in the synthesis of the beta chain of the hemoglobin molecule. This unstable unit results in damaged red blood cells causing severe anemia. This is genetically determined by an autosomal recessive pattern of inheritance. This is most commonly seen in Italian, Greek, and Southeast Asian and African ancestry. Signs and symptoms before diagnosis include unexplained fever, poor feeding, a greatly enlarged spleen. With progressive anemia, you can see signs of chronic hypoxia, headache, precordial pain, bone pain, decreased exercise tolerance, listlessness, and anorexia. Other features include small stature, delayed sexual maturation, and a bronzed, freckled complexion if they are not chelated. They can also have bone changes. Treatment. Frequent and regular blood transfusions of packed red blood cells to maintain hemoglobin levels above 9.5. Washed packed RBCs are usually used to minimize the possibility of transfusion reactions. If this is not available, leukofiltered cells can be substituted. The frequency of the amount of transfusion depends on the size of the child. It's usually 10 to 15 milliliters of RBCs per kilogram body weight every 3 to 5 weeks. It really does depend on their lab work. Iron chelation therapy with a deferoxamine reduces the toxic side effects of excess iron in the organs, which is called hemosiderosis. Increases iron excretion through urine and feces. So that is what deferoxamine will do. An iron chelating agent is given with small oral supplements of vitamin C. Here, the chelation is given IV infusion, approximately 100 to 150 milligrams per kilogram per day. This is given typically at the same time while the blood transfusion is being given. Or if a child is having, they have a very high iron levels, or they have poor compliance with home chelation therapy, they can be given this as well. Subcutaneous infusion of the deferoxamine can be given 50 milligrams per kilogram a day. This is usually infused overnight for home therapy. And this helps to maintain the iron excretion to prevent toxic effects of the iron. Splenectomy, supportive management of complications, and possibly hematopoietic stem cell transplant are a possibility. Survival rate is 85 to 90%. Young patients with few complications are good candidates for the hematopoietic stem cell transplantation. Nursing, we want to promote compliance with transfusion and chelation therapy. Assist the child in coping with anxiety. Know that there can be anxiety-provoking treatments like starting IVs frequently, and children generally don't like needles. Also, we want to foster the child's and the family's adjustment to a chronic disease. Observe for complications of blood transfusions. Make sure that the parents have genetic counseling, and support the teen by giving them information on how to look their age, because it's not uncommon for children that have this condition for them to look younger than their stated age. Aplastic anemia. This is not a single disease. It's a group of closely related disorders characterized by the failure of the bone marrow to produce all three types of blood cells: the red blood cells, the white blood cells, and the platelets. This may be congenital. This is called Fanconi syndrome. This is extremely rare. This is also can be acquired due to infections like HPV, hepatitis, and mononucleosis. Drug reactions also can cause this, things like chloramphenicol and sulfonamides. Radiation and chemotherapy can also cause aplastic anemia. Also, exposure to insecticides, benzene, and lead can contribute to this diagnosis. Signs and symptoms. This is really based on the degree of bone marrow failure. You can see things like petechiae, purpura, and frank bleeding, muscle weakness, fatigue, shortness of breath, poor sucking, pale skin, pica, headache, dizziness, lightheadedness, slow thought process, decreased attention span, apathy, depression, moist and cool skins, a decreased blood pressure, and increased heart rate. Diagnosis. So they can have leukopenia, neutropenia, thrombocytopenia, pancytopenia. The definitive diagnosis is a bone marrow aspiration that'll show a conversion of red marrow to yellow marrow and a great reduction in the number of cells. The treatment is irradiation, immunosuppression, bone marrow transplantation, RBC and platelet transfusion, anti-lymphocyte globulin, antithymocyte globulin, and cyclosporins are the principal drugs of treatment. Know that colony-stimulating factors that stimulate the marrow to produce the blood cells may also be given. Prior to a bone marrow transplant, the child must be hospitalized to medically suppress the immune system. A bone marrow transplantation from the compatible sibling or parent is the treatment of choice. Nursing, we want to prevent issues with bleeding and infection. The family needs lots of emotional support because this can be life-threatening. You want to place a child in a private room to minimize exposure to infective organisms. Advise all visitors and staff to use good hand washing techniques. Anyone who's ill should not visit this patient. Monitor vital signs, especially the temperature, to detect possible infection. Provide nutritionally complete diet for the age to support the body's natural defenses. Administer the medications as prescribed. Explain any procedures carefully at the child's developmental level to increase their understanding and to reduce their fear of the unknown. Observe for any signs of transfusion reactions, things like chills, shaking, fever, and pain at the needle site. Also teach the parents about the disease process and monitor the lab values. Hemophilia. Hemophilia A, this is also called classic hemophilia, is caused by a deficiency in factor VIII. This is about 80% of the cases. Hemophilia B, or Christmas disease, is a deficiency in factor IX. This is about 15% of the cases. Von Willebrand disease is an absence of a protein called von Willebrand and a deficiency of factor VIII. This occurs in both males and females. This is an X-linked recessive trait. Girls get the carrier trait from the father and have a 50% chance of each pregnancy of giving this to their sons. So just kind of for clarity, von Willebrand can occur in both genders, but the regular hemophilia A and B occurs in the boys. 1/3 have no family history. This may mean that there is a new mutation. So here, basically, there's a defect in the hemophilia A, and there's a deficiency of factor VIII. This accounts for 80% of the cases. So they are missing the antihemolytic factor. This antihemolytic factor is produced by the liver and is necessary for the formation of thromboplastin in phase 1 of blood coagulations. The less antihemolytic factor found in the blood, the more severe the disease. Individuals with hemophilia have 2 of the 3 factors required for coagulation. So they have the vascular influence and platelets. They're just missing the antihemolytic factor, or they only have a certain percentage of it. Please note that they may bleed for longer periods, but not faster. Bleeding can occur in tissues anywhere. Hemorrhage into the joints, cavities, especially the knees, elbows, and ankles, can occur. Also, muscles are the most frequent type of internal bleeding. After a platelet plug develops at a bleeding site, the lack of the clotting factor can prevent a stable fibrin clot from forming. Therefore, blood may ooze slowly or start and stop for up to 8 days after surgery. Diagnosis, history and physical. The labs show a decrease in the factor VIII or IX, prolonged activated partial prothrombin. PT, fibrinogen, and platelets are normal. So signs and symptoms, it's really prolonged bleeding from anywhere in the body. Hemorrhage from any trauma, loss of the baby teeth, circumcisions, cuts, bloody noses, injections, excessive bruising, even from just a slight injury such as a minor fall. Subcutaneous and intramuscular hemorrhages can also develop. Hemarthrosis, which is bleeding into the joint cavities, as I mentioned before, especially in the knees, ankles, and elbows, can develop. Hematomas, here you would see pain, swelling, limited range of motion. And they can even develop a spontaneous hematuria. Treatment: control bleeding by replacing the missing clotting factors. DDAVP, which is a type of vasopressin, IV, can increase factor VIII activity. Note this also can be given inhaled. Transfusions for bleeding will also be done as necessary. Nursing, here we want to prevent bleeding by making the environment as safe as possible. Infants and toddlers are prone to falling. No contact sports. Swimming is a good alternative. They want to use electric razors when shaving, use a water pick, or a very soft sponge toothette or a soft moistened toothbrush. No aspirin. We want to avoid iron injections if possible. If they have a hemarthrosis, we want to immobilize the joint and control the bleeding with RICE, rest, ice, compression, elevate. If they do have bleeding, we want to apply pressure for at least 15 minutes and we want to stop the bleeding. Do range of motion after bleeding is stopped. Physical therapy with good preventative pain control can be very helpful. No rectal temperatures or suppositories. Make sure this person is wearing a medical alert bracelet. It is important to maintain a normal rate to help to prevent issues with the joints. Wear protective gear such as padding and helmets. Head injury can be life-threatening. Keep ice packs available in the freezer in the event of bleeding. Genetic counseling and support the family. These are all important. Once a child reaches 26 years of age, many insurance companies may not carry them. Financial support is very important for these people. Hemophilia, the factor replacement therapy, is very, very expensive. Leukemia. This is a broad term given to a group of malignant diseases of the bone marrow and lymphatic system. It is an unrestricted proliferation of immature white cells in the blood-forming tissues in the body. The most common type is ALL. The peak onset is between 2 and 5 years of age, more often in males and females, and in Caucasians. The survivability of ALL is about 80%. 90 to 95% with ALL will achieve a first remission, and almost 90% will live 5 years. Children between the ages of 3 and 5 with ALL, and they had an initial white blood cell count of less than 50,000 at the time of diagnosis, have the best prognosis. AML is a type of cancer in which the bone marrow makes abnormal myeloblasts, precursors of the granulocytes, red blood cells, or platelets. Acute myelogenous leukemia has no set age onset and occurs in all ethnic groups. This is more common than ALL in adolescents. Here, there's an 85 to 90% of adolescents with AML will reach a first remission. 55 to 65% live 5 years. Death usually follows an overwhelming infection. Children with trisomy 21, also called Down syndrome, have a 20 times greater risk for developing ALL. Children with more than 50 chromosomes on the leukemic cells have the best prognosis. Specific translocations of the chromosomes on the leukemic cells also can affect prognosis. Signs and symptoms. The 3 main problems are anemia, infection, and bleeding. Other signs and symptoms can include malaise, fever, pallor, anorexia, weight loss, muscle wasting, hepatosplenomegaly, and large lymph nodes, bone and joint pain. If CNS is involved, they can have headaches, vomiting, papilledema, stiff neck and back. They can be irritable and lethargic. Diagnosis. The definitive diagnosis is a bone marrow aspiration. Here you will see abnormal immature lymphoblasts and hypercellular marrow. You can also do a biopsy. A lumbar puncture may be done to see if there is any CNS involvement. Treatment of leukemia involves the use of chemotherapy agents with or without cranial irradiation. It can occur in 4 phases. Induction therapy is the first phase, intensification therapy is the second, maintenance therapy is the third, and then CNS prophylaxis is the fourth. Chemotherapy in ALL can result in tumor lysis syndrome due to the release of purines from the destroyed leukemic lymphoblast. Treatment includes allopurinol, rasburicase, and eye dehydration. Exchange transfusions may be used in severe cases. Cranial irradiation may be used in some cases. This would be used for resistant central nervous system disease or testicular relapse. Hematopoietic stem cell transplantation is something that can be suitable. Patients with intermediate and high-risk AML, if they have a suitable donor, can be recommended during the first clinical remission. There are some risks associated with this. These include risk of morbidity and mortality, graft versus host disease, overwhelming infection, severe organ damage. The possibility of a cure after the hematopoietic stem cell transplant can occur in up to 60 to 70 cases. Unfortunately, if they relapse, the prognosis is then very, very poor. Identifying factors to help determine prognosis. Here is basically the initial white blood cell count, the age at the time of diagnosis, the type of cells involved, gender and karyotype analysis. Children diagnosed between 2 and 10 have a better outlook than those diagnosed before 2 or after 10. Girls have a more favorable prognosis than boys. Nursing care. Please prepare the child and the family for all of the procedures. Manage their pain, prevent the complications of myelosuppression. Please note that there is an increase of susceptibility to infections during various times during their disease process, specifically at the time of diagnosis, and if they have a relapse, during immunosuppressive therapy, after prolonged antibiotic therapy, because this can predispose the patient to growth of resistant organisms. Infection control, making sure the environment is very, very clean, good hand hygiene, visitor restriction. Remember, anyone who's ill should not visit this patient. And nutrition, they should be on a low microbial diet. A low microbial diet, there are foods you want to avoid. Things like unpasteurized or raw milk, unpasteurized cheese or yogurts, cheeses from delicatessens, anything that is soft or moldy, anything that is raw in terms of oats or grains, we want them to be cooked. In terms of meat, fish, and protein, we do not want anyone to be fed raw or undercooked meat, poultry, fish, game, tofu, or runny eggs. These all must be thoroughly cooked on a low microbial diet. Also things like hard-cured salami in a natural wrap, or cold smoked salmon, or lox or pickled fish should be avoided. Fruits and nuts. Here, unwashed raw fruits should be avoided. If they're going to eat raw fruits, they must be scrubbed super well. They really should avoid raw berries because they're too difficult to get clean. Unroasted or raw nuts, roasted nuts in the shell, non-pasteurized fruit or vegetable juices, all of these should be avoided. Any type of fresh fruit salsa or fresh salad mix that are in the refrigerator section of a grocery store should be avoided. Also, any kind of unwashed raw fruits or herbs. Salads from delicatessens or salad bars should be avoided. Also, unwashed and uncooked mushrooms should be avoided. Water. In general, water from the tap is typically okay. Water from a well, this would be something that you would want to boil unless it's tested every year and found to be safe. Again, avoiding unpasteurized fruit and vegetable juices. In terms of desserts, any kind of unrefrigerated cream-filled pastries or products should be avoided. So, nursing care, very gentle assessment. Check for signs and symptoms of bleeding, infection, especially after chemotherapy and/or radiation. Monitor intake and output. Weigh the patient daily using the same scale with the same clothing at the same time of day. Monitor for kidney function. Monitor for oral sores, nausea and vomiting, constipation as well. Monitor the dietary intake. Be aware of behavioral changes such as irritability and lethargy. We should have very good pain management. Also monitor for neutropenic problems as well as bleeding issues, and then institute neutropenic precautions and bleeding precautions. Teach parents to monitor the temperature daily and to observe for signs and symptoms of infection. Provide support to the family and the child and connect them to a support group. Lymphomas. Here, these are a neoplastic disease originating in the lymphoid system. They may metastasize to non-lymph node sites. A group of neoplastic diseases that arise from the lymphoid and hematopoietic systems are divided into two areas, Hodgkin's disease and non-Hodgkin's lymphoma. These diseases are further subdivided according to tissue type and the extent of the disease, which is the staging. In children with non-Hodgkin's lymphoma, know that it's more common than Hodgkin's disease. Although Hodgkin's disease is extremely rare before 5 years of age, there's a striking increase in children 15 to 19 years of age. Know that it can actually occur with maybe the same frequency as leukemia. So Hodgkin's disease. This is a neoplastic disease that originates in the lymphoid system and primarily involves the lymph nodes. This is prevalent in adolescence and the young adult period, with a striking increase between the ages of 15 and 19. An Ann Arbor staging classification system is one basis for treatment and prognosis. Subtype A has a much better prognosis. The Ann Arbor staging system assigns a stage based on the number of sites of lymph node involvement, presence of extranodal disease, and a history of any other symptoms. So know there are 4 stages. Stage 1, the lesions are limited to 1 lymph node or 1 additional extralymphatic site. Stage 2 is 2 or more lymph node regions on the same side of the diaphragm, or 1 additional extralymphatic site or organ on the same side of the diaphragm. Stage 3, lymph node regions on both sides of the diaphragm are involved, or 1 extralymphatic site. Stage 4, the cancer has metastasized diffusely throughout the body to 1 or more extralymphatic sites with or without involvement of associated lymph nodes. So the signs and symptoms include painless enlargement of the lymph nodes, enlarged, firm, non-tender, movable nodes in the cervical area, most common in the sentinel node area, which is located near the left clavicle. This might be the first enlarged lymph node. Axillary and inguinal lymph nodes occur less frequently. Other signs and symptoms include lymphadenopathy, and large mediastinal nodes can cause persistent, non-productive cough, and large retroperitoneal nodes can produce an unexplained abdominal pain. Systemic symptoms include, and usually this indicates an advanced involvement, a low-grade and or intermittent fever, night sweats, anorexia, nausea, unexplained weight loss, and itching. Prognosis. If it's caught early, 90% survival rate. If it's caught late, 65 to 75% survival rate. Diagnosis. Here, we're looking at history and physical. Since multiple organs can be involved, multiple tests may need to be done for accurate staging. CBC liver function test, ESR, uric acid levels, a CT of the neck, chest, abdomen, and pelvis area, bone scans to check for metastasis, a biopsy of the large lymph node to see for the presence of Reed-Sternberg cells is characteristic of Hodgkin's disease. But please note that this can also be seen in infectious mononucleosis. Treatment, radiation and or chemotherapy. Radiation can cause infertility, so males may want to use sperm banking before treatments. Non-Hodgkin's lymphoma. This occurs in 10 cases per million under the age of 20. It's very different from Hodgkin's disease in that it is diffuse versus nodular. The cell is either undifferentiated or poorly differentiated. Dissemination occurs early, more often, and more rapidly. Mediastinal involvement and invasion of the meninges often occurs. The signs and symptoms depend on the site and the extent of involvement. Fever, weight loss, and large lymph glands can occur. The non-Hodgkin's lymphoma typically involves the lymph glands of the neck and the chest most commonly. Although axillary, abdominal, or inguinal nodes may be also initially involved. If mediastinal lymph glands are swollen, the child may have a cough or chest tightness. If mediastinal nodes press on the veins returning to the blood from the head, they may have edema of the face. If abdominal nodes are involved, the child may notice abdominal pain and they can have diarrhea or constipation. Diagnosis. Surgical biopsy can confirm the diagnosis. They may also have a bone marrow aspiration, CT of the lungs and GI organs, as well as a lumbar puncture. Know that the child may have, or the adolescent may have, an advanced disease at the time of diagnosis. Treatment, aggressive radiation and chemotherapy for 6 to 24 months. Again, 85 to 95% survival rate with limited disease, 70 to 90% with extensive disease. Neuroblastoma. This is the most common extracranial solid tumor of childhood and is the most common cancer diagnosed in infancy. The median age at diagnosis is 19 months. These tumors originate from embryonic neural crest cells in the adrenal medulla and the sympathetic nervous system. The majority of tumors arise from the adrenal gland or from the retroperitoneal sympathetic chain. Primary site is within the abdomen. Other sites include the head and neck region, chest, and pelvis. Clinical manifestations. The signs and symptoms of neuroblastoma depend on the location and the stage of the disease. With abdominal tumors, the most common presenting sign is a firm, non-tender, irregular mass in the abdomen that crosses the midline. This is in contrast to Wilms tumor, which is usually confined to one side. Other primary tumor sites may cause significant clinical effects such as neurological impairment, respiratory obstruction from a thoracic mass, or varying degrees of paralysis from compression of the spinal cord. Distant metastases frequently cause supraorbital ecchymosis, periorbital edema, and proptosis from the invasion of the retrobulbar soft tissue areas. Lymphadenopathy, hepatomegaly, and skeletal pain are also present in patients with disseminated disease. Vague symptoms of widespread metastasis include pallor, weakness, irritability, anorexia, and weight loss. Diagnostic evaluation. This is aimed at locating the primary site and the areas of metastasis. A CT scan of the abdomen, pelvis, and or chest is the preferred imaging modality to locate the primary tumor. A bone scan and a MIBG scan should be performed to evaluate the presence of skeletal metastasis. Bone marrow biopsies may also be done. Please note that neuroblastomas, particularly those arising on the adrenal, or from the sympathetic chain excrete the catecholamines epinephrine and norepinephrine. Urinary excretion of catecholamines is detected in about 95% of children with adrenal or sympathetic tumors. Staging and prognosis. Neuroblastoma is a silent tumor. In more than 70% of cases, diagnosis is made after metastasis occurs, with the first signs caused by involvement in the non-primary site, usually the lymph nodes, bone marrow, skeletal system, or liver. Because of the frequency of invasiveness, the prognosis for neuroblastoma is unfortunately very poor. The child's age and the stage of the disease at the time of diagnosis are important prognostic factors. Survival is inversely correlated with age. So for a child who is 1 year old and less, the survival rate is about 80%. But for a child who is older than 1 year of age, it is less than 50%. Infants who remain free of disease for 1 year after treatment are usually cured, but older children have experienced relapses several years after cessation of treatment. Surgical resection of all the tumor may occur in stage 1, and this can have a greater than 90% curative rate. Neuroblastoma is actually one of the few tumors that will demonstrate a spontaneous regression. This is possibly a result of maturity of the embryonic cells or development of an active immune system. So therapeutic management, staging is important for initial therapy. Surgery is both to remove as much of the tumor as possible and to obtain biopsies. In stages 1 and 2, complete surgical removal of the tumor is the treatment of choice. If the tumors are large, partial resection is attempted with a course of irradiation postoperatively to shrink the tumor in the hopes that complete removal can occur at a later date. Surgery is usually limited to biopsies in stages 3 and 4 because of the extensive metastasis. Chemotherapy protocols are the mainstay of therapy for extensive local or disseminated disease. Wilms tumor. This is also called nephroblastoma. This is the most common abdominal tumor and renal cancer. It may be associated with other congenital problems such as no iris, hypospadias, cryptorchidism, ambiguous genitalia. It is slightly more often in the left kidney. Peak age is between 2 and 3 years of age. 10% of the cases involve both kidneys, a little bit more often in boys than girls. Signs and symptoms. Here you have abdominal swelling or mass. It tends to be firm and non-tender and confined to one side. They may have hematuria, although this occurs in less than 1/4 of the cases. They may have fatigue and malaise, hypertension occasionally, unexplained weight loss, fever, manifestations resulting from compression of the tumor mass can also occur. And then secondary metabolic alterations from the tumor or metastasis can occur. If they have metastasis, they may have symptoms of lung involvement if this is where it has metastasized. Things we would see here would be things like dyspnea, cough, shortness of breath, and chest pain. Diagnosis. Here's history and physical, looking at the BU and creatinine, liver function test, and abdominal ultrasound. They will also do IVPs, CTs, and MRIs of the body to check for metastasis. In general, biopsies are not usually done because typically this is an encapsulated tumor and we don't want part of the tumor to dislodge and cause metastasis. Do not palpate the abdomen. Again, you do not want part of the tumor to dislodge. Handle the child very gently when you're bathing them. Treatment, chemotherapy and irradiation before and or after surgery. Surgery to remove the tumor and the kidney. Surgery generally takes place within 24 to 48 hours after diagnosis. Please be aware that the parents and the child, because this happens so quickly, can be very, very anxious. Postoperatively, monitoring vital signs, hemorrhage, pain management, strict intake and output, their weight, urine-specific gravity, monitor renal function. Remember, the removed one, so it's important to monitor for this. Monitor lung sounds, bowel sounds, monitor for signs and symptoms of infection. If a child had a central line placed, this is not uncommon to occur because they will be requiring chemotherapy. Please monitor for signs and symptoms of infection and functioning, and then monitor for side effects of chemotherapy and irradiation. Once a child is recovered, the child needs to avoid contact sports because they only have one kidney and we need to prevent injury to that kidney. Prognosis, if stage 1 or 2, the cure rate is about 90%. Next, we're going to talk about, in general, the care of the child with cancer. And we're going to talk about some side effects of radiation and chemotherapy, and then we're going to address what can we do as a nurse. So in terms of radiation, gastrointestinal tract, nausea and vomiting, what can we do as a nurse? Give the antiemetics around the clock. Also, we want to measure the emesis and assess for signs and symptoms of dehydration. Anorexia, we want to encourage foods and fluids that are best tolerated, usually a light, soft diet with small, frequent meals. Again, really monitor for that weight loss. Mucosal ulcerations, here they would want to use mouth rinses without alcohol, so they can use normal saline rinses. Also, gentle, good oral hygiene to prevent issues with mucositis. Diarrhea, this can be controlled with antispasmodics and kaolin pectin preparations. Again, observe for signs of dehydration. Skin, alopecia, this is the balding. This can begin within 2 weeks, but typically the hair will regrow within 3 to 6 months after therapy. Introduce the idea of a wig, maybe even before therapy starts. Stress the necessity of scalp hygiene and to keep the head covered in cool weather. They may experience a dry or moist desquamation of the skin. Do not refer to this skin change as a burn because it can be misinterpreted that they are getting too much radiation. Again, gently keep the skin clean. Clean it daily using soap very sparingly. Do not remove the skin markings for radiation fields. The radiologist needs this because this is going to indicate where they need to give the radiation. Avoid exposure to the sun. If their skin is very dry and peeling, you want to apply a lubricant. And if they're having significant issues, definitely consult a practitioner for skin hygiene and care. Head. Again, nausea and vomiting because they can have a stimulation of the vomiting center in the brain. So we already talked about that. So potential effects of parotitis, sore throat, and loss of taste, and dry mouth. What can we do here? They may need analgesics to relieve the discomfort. Combat severe dryness of the mouth with oral hygiene and liquid diets. We don't use lemon swabs because those are very drying. The urinary bladder, hemorrhagic cystitis. This is more likely to occur with concomitant use of cyclophosphamide or cytazan. Encourage liberal fluid intake and frequent voiding, and also please evaluate for hematuria. Bone marrow, myelosuppression. Here we need to monitor for signs of a fever. The initial workup for sepsis will be ordered, typically if they have a fever over 100.4. Administer antibiotics as prescribed, avoid suppositories, rectal temperatures, and institute bleeding precautions. Also observe for signs of anemia. If a patient has a radioactive implant, nurses need to wear a dosimeter badge. We need to keep the nurses safe as well. We don't want them to have too much radiation exposure. Please note that every month the company will test the badge to determine how much exposure the nurse has had. Once they meet the limit, they are no longer able to care for patients that have had the radiation. You should flush the toilet 2 times when a patient who's on radiation has voided. or has put anything, any bodily excrements into the toilet, because the waste is considered to be contaminated with radiation. When the child goes home, they should close the toilet seat and close the door, and then flush the toilet 2 times. If an implant falls out, do not touch it. Typically, the room will have 3-foot tongs. You will pick it up with the tongs and place it in the container that the radiology department left for you in the event that the radioactive implant fell out. And then you're going to call the radiology department. They will pick it up and they will handle it. Next, we're going to talk about the effects of chemotherapy on various body areas, and then what can we do? So, bone marrow suppression. Typically, evidence of suppression usually happens 7 to 10 days after administration of chemotherapy. This is referred to as a nadir. This is the time of the expected lowest blood count. Recovery is usually complete within 3 to 4 weeks. Transfusions are administered when anemia is severe, a hemoglobin of less than 7, or the platelets are less than 20,000. An ANC of 500 or less can result in opportunistic infections. Some institutions use a low microbial diet to decrease the possibility that infectious organisms will colonize the intestine. Septra or Bactrim can be used for Pneumocystis carinii pneumonia prophylaxis. Nystatin and oral vancomycin can be used for antifungal and antibacterial prophylaxis. Nursing, instructing the family and the child about the importance of protecting the body from bruising during periods of mild to moderate thrombocytopenia. So moderate thrombocytopenia is 50,000. If they have an injection site, it would be important to apply pressure for at least 5 minutes. We want to get the bleeding to stop. Again, no rectal temperatures, avoid tampon use. They should not be having sex. Avoid NSAIDs and aspirin. Careful hand washing is essential. Encourage the use of masks if family members or staff have any kind of upper respiratory signs and symptoms. Please note that signs of infection may only include pain and swelling. Nausea and vomiting. Here, symptoms can occur immediately or 5 to 6 hours after the administration of chemotherapy, and they can last as long as 48 hours. Antiemetics such as ondansetron, Kytril, Reglan, and Benadryl can be used to treat this side effect. You want to give it before chemotherapy begins. Let's prevent that nausea and vomiting feeling. Nursing, we can teach relaxation techniques, hypnosis, and systematic desensitization. Also, we want to help to decrease the child's symptoms, encourage mild exercise, and maybe even changing their diet to easily digestible foods 12 hours before chemotherapy. Even though it's difficult to do, you want to relax the pressures for the child to eat. When you're not hungry and people keep telling you, you've got to eat, you've got to eat, you've got to eat, it just makes you very frustrated, because it's not that you don't want to eat, it's just that you're nauseous and vomiting, and nobody wants to eat when they're nauseous and vomiting. Anorexia and weight loss. This may occur at any time. They may even need hyperalimentation therapy if weight loss is not stopped. Please pay very careful attention to any changes in taste that affect food preferences. Some of the medications can cause this. They may need to be referred to a dietitian to achieve appropriate nutritional state. Mouth sores. Oral mucositis resulting from chemotherapy can usually occur within 3 to 4 days and is often a contributing factor in anorexia. Antifungal agents such as nystatin and clotrimazole can lessen the possibility of a candida infection. We want to promote good oral hygiene using a very soft foam wand or water irrigation to clean the teeth. Generally, we don't want to use commercial mouthwashes because they contain alcohol and they can be very drying to the oral cavity, causing further irritation. Constipation. Here they'll give stool softeners as well as laxatives. Advise parents to increase the fluids and fibrous foods in the child's diet if it's possible. Pain. So our medical management for pain would include acetaminophen, morphine, steroids, non-steroidal anti-inflammatory drugs, and even some antidepressants may be used as adjuncts to manage pain. Demerol, again, not usually used because of its neuroexcitability. It can cause anxiety, irritability, and seizure activity. Nursing interventions. Careful pain assessment is important. The location of the pain will provide a clue to its cause. For example, if they have a metastasis to the skull, infiltration of the joints, or damage to soft tissue, pain associated with chemotherapy may also be related to oral mucositis, myalgia, or tumor embolization. Painful polyneuropathy can follow treatment with vincristine or cisplatin. Acetaminophen for pain can mask the presence of a fever, which can signal infection. A careful and complete physical assessment is needed to identify infection. They may actually take the child's temperature before giving acetaminophen. Pharmacologics and non-hypnotic deep breathing and self-control and hypnotic methods of pain control may be used. Please note that non-pharmacological methods often prove helpful to children with pain from multiple etiologies. A safety alert for children under the age of 3. We generally don't want to use viscous lidocaine in young children. If it's applied to their pharynx, it can decrease their gag reflex and increase their risk for aspiration. Also of note, when a child loses their hair and it grows back, it may regrow a little bit different color, and it may have a little bit of a different texture. So please let them know this. Signs and symptoms that the parents and the family should report if the child is receiving chemotherapy. So if they have a temperature of 100.4 or above, any bleeding such as nosebleeds, blood in the stool or urine, petechiae or bruising, pain or discomfort with urination or defecation, sores in the mouth, vomiting or diarrhea, persistent pain anywhere, including headache, signs of infection such as cough, fever, runny nose, or tugging at the ears, signs of infection in the central line such as redness and drainage or tenderness at the site. Please note that exposure to communicable diseases, especially varicella, chickenpox, these children will need the varicella immunoglobulin. Inform dentists or other healthcare providers that the child is receiving chemotherapy prior to any procedures. Prophylactic antibiotics should be given before and after care. Immunizations are often held approximately 6 months after chemotherapy is stopped. If vaccinated 2 weeks or less before or during chemotherapy was started, they are considered unimmunized. Live virus vaccines are generally reviewed as absolutely contraindicated. Things like that, MMR, varicella, rotavirus, and the inhaled flu vaccine. This concludes the lecture addressing the behavioral objectives for week 7. This is week 7, part B objectives. Please be sure to read your textbook and complete the all of the assignments for this week to facilitate the utilization of this content and apply it to nursing practice. Also, please remember, make sure you watch week 7, part A. Thank you and have a good day.